Okay, hello everyone. I will get started. Thanks for joining us again. I know we missed last month's thrombosis round. Good to have everyone back. I think today it's about sharing. We are starting an anticoagulation stewardship program at St. Paul's Hospital. Just started. We really want to share this experience with all the colleagues across BC, and perhaps that's something that other people have tried. So hoping to learn from everyone else. And before I start, I want to introduce Stephanie. I think she's here. She is our new clinical pharmacist specialist for the coagulation stewardship program. She also works with Haley Merkley here at the hematology clinic. So she's done a lot of this work. So Stephanie, please correct me if I said something wrong. And I'll get started and I'll show you guys how we started and what really brought us here. So heparin, it's been a little bit over than 100 years now since it was discovered, and we've been using it. It was discovered in Johns Hopkins by a pair of physiologists, a teacher and a student. And since then, it has made into the WHO list of essential medication. And I also want to point out the Canadian contributions. A few Canadian scientists was instrumental in developing a way to mass produce heparin. As you can imagine, it's not an easy process, even now. And this was a lab in Toronto where they designed the process. Back then, they used different types of tissues, animal tissues from the lung of the sheep, the intestine of the cow. But overall, I don't think that's changed too much these days. That's the heparin molecule. And when they first discovered it, they call it the miracle blood lubricant. And this miracle to this day is still, is the only way to get it is from animal tissue. And now is, at least in North America and Europe, it's almost exclusively from pig intestine. A few years back, we went through a few crises when the heparin supply was contaminated from cow tissue to other tissues. So now is a very much a regulated process. Brief illustration of the supply chain of heparin. It starts from usually a slaughterhouse where they harvest the intestines, going to certain types of factories and plants, and then the process begins again. It's not an easy process. It's a lot that goes into it that we as providers don't usually see. And it really sparked an interest in me when I was looking into this topic. It brings up a lot of ethical issues as well. So I'm hoping that we can highlight some of them in today's talk. And it just gives me a sense that we don't practice medicine in a vacuum. There's a lot of things that are around us that supports us. There was a New York Times article a few years back where they basically wrote a piece about a family in rural China producing heparin, or part of the process. As you can see, the working environment is not great, and not only is it dangerous for the workers, it also introduces a lot of opportunity for contamination, and ultimately it will be our patients who suffer. And right now, I think there is a great push to further regulate it, as almost half of the heparin supply is still produced by China, and it makes the supply chain quite unstable. So we'll start here and talk about our anticoagulation stewardship program and how it fits into the big picture. And I want to say that it's still an unknown journey. It's a relatively new concept. We've had antimicrobial stewardship for many years, but It's not until about 2019 when the Anticoagulation Forum really formally defined what anticoagulation stewardship may mean. So that is 9 zeros or 1.1 billion. That's how many pigs we kill every year to supply the world with heparin. It is an extremely inefficient process. Just to put things into perspective, we, the world, consume about 1.4 billion pigs for food every year. It really gives you a setting or a context in terms of how much resources go into heparin production. It is a big business. This is just the US data, or I should say North America data. It's almost 5 billion as of 2021, and it's projected to increase. And one thing that I learned while researching this topic is the COVID pandemic actually increased the heparin demand quite a bit, because when the disease came out, there was a great interest in people clotting. So there's more use of heparin, and really shows in some of the data. One adult pig will give us approximately 1 kilogram of intestine mucosa. It is only mucosa that will be used for the heparin source, not other parts of the intestine. Even in the best case scenario, that can only yield about 160 to 260 milligrams of crude heparin. And when you make that into low molecular heparin, is again not a very efficient process. You probably get maybe 3 or 4 syringes of enoxaparin 40 milligrams, the most common thromboprophylaxis we use, probably less. And that whole process will give you about 6.1 kilogram equivalent of carbon dioxide. So what does that mean? That's 6.1. When we looked it up, it's approximately the amount of CO2 you emit for driving 24 kilometers. And 24 kilometers is approximately from Royal Columbian to St. Paul's. So just imagine every time you prescribe 1 or 2 days of prophylaxis in hospital, the carbon cost is like driving from Royal Columbian to St. Paul's. Not a small amount when we consider how many people are on the thromboprophylaxis in hospital. Now that is the sort of the global picture, the global impact of heparin. As providers, I think most of you agree with me, those are the 2 things that are usually in my mind when I prescribe heparin or anticoagulant. Am I going to cause bleeding, or am I going to cause HIT? Important outcomes, but hopefully in this presentation I can highlight things that are beyond this on a more global scale. The Anticoagulation Forum formally defined anticoagulation stewardship as a coordinated, efficient, and sustainable system-level initiative designed to achieve optimal anticoagulant-related health outcomes and minimize adverse event. And like I said, unlike antimicrobial stewardship, this is a relatively new concept. So, what type of experiences can we learn from, and where do we find them? And I think we are very fortunate that Canada is a leading, academic leader in thrombosis and anticoagulation. There's no doubt about it. And even within our own border, we can find good experiences around. First, we're going to go to Toronto, specifically Sunnybrook Hospital. Fairly big hospital. It's about the same size as St. Paul's, actually. They have about 450 beds, a major cardiac center. So in a way, there's a lot of similarity to us who work in St. Paul's Hospital. A little bit smaller than Vancouver General Hospital. One of the hematologists there, Dr. McKieran, started the Avoid Heparin Initiative quite a few years ago. It's way before the talk about stewardship really came out. And I was fascinated by it, and they achieved amazing results. Essentially, what they did was overnight, they switch off, or just switch all the low unfractionated heparin to low mercury heparin. And it was sort of a daring process, because I don't think this can be repeated nowadays. Basically, none of the physicians were told. Basically, every single provider in the hospital was blind. Their pharmacy group went in and systematically switched any unfractionated heparin order to low mercury heparin. There's no consulting any physicians. All the lines were now flushed with saline instead of any heparin type of material. They also switched off, they switched all the paper order sets. Unfractionated heparin is no longer option on paper order sets. And they've went so far to remove all the heparins from the nursing stations. So it's not even accessible. There are only a few areas that were not involved, ICU and the cardiac surgery units. But again, this is, to me, a very interesting strategy, but I find it difficult or impossible to replicate in nowadays. And their result was very striking. In 2006, that's when they started it. And on the y-axis here is the number of, or the prevalence of HIT per 10,000 admissions. And they've also divided HIT to HIT without clot and HIT with clot. As soon as the program started, is very dramatically in this one chart, we can see the number of HIT and HIT with the T decreasing substantially. Nowadays, it's very, very rare, almost nil, HITT. That is very striking. For people who are more used to academic way of reporting results instead of a QI way, you can also compare it and do some statistics. It was quite significant, as you can see with the results, both reducing confirmed HIT, positive HIT assay, or suspected HIT. They followed this up with a cost analysis, and as we can imagine, the costs have reduced because HIT is a very morbid condition that requires intensive therapy. Many people are in ICU. It's been reported that up to 10 to 15% of the patient will lose a limb, and the mortality rate is quite high. If you calculate it bit by bit, it looks like they were able to reduce the total financial cost of managing HIT in the hospital from well over 300,000 to about 50,000. Again, these are numbers from about 10, 15 years ago. Nowadays, this number will be much more dramatic. Next, we're going to go to Montreal, specifically the Jewish hospital, where they have one of the 3 thrombosis AFC programs in Canada. This is a more recent program as compared to Sunnybrook. It started only 3-4 years ago, I think right around the time the pandemic started. They built a multidisciplinary team of pharmacists and MDs. The goal is to review all the admitted patients who were put on a therapeutic strength anticoagulation. Doesn't have to be heparin, it can be direct oral anticoagulant, can also be warfarin. And they will review it and provide recommendations according to Canadian and clinical guidelines. The little caveat is that in that hospital, only a few wards have the dedicated pharmacists. And if there is actually a specific pharmacist in a specific ward, the stewardship team will not review it. For example, I believe some of their medicine teams do have a pharmacist. After, I think, about 6 months of experience, they published this. And on the column, it shows how many recommendations were made, or I should say how many review charts require a recommendation. To me, this is quite striking. This is basically saying that 60% of the therapeutic anticoagulation order in that hospital can be optimized, and that's a lot. And only in 36% where when they review everything according to the guideline, the indication, the dose, the drug was actually all aligned with the guidelines. That to me is very striking. And I think on the column on the B, it shows you how often the MRP accept the recommendation. So about 84% of the time, the treating team will accept the recommendation, and sometimes they don't. And this chart describes the type of recommendation that the stewardship team made. 20% drug interaction, that's a lot. Again, basically 2 in 10 patients who would prescribe an anticoagulant has some sort of drug interaction, potentially adverse effect. Dosing adjustment, they didn't go into the specific detail, but they also include warfarin as a drug that they review. I sort of assumed that may be one of the reasons why. Dose adjustment was a big part of their recommendation. Other things including change of drug if needed, complex patient that requires thrombosis console, or other drugs that require more lab monitoring. All right, so with that in mind, what are we doing now in St. Paul's? I found this picture of how St. Paul's initially looked like back in, I think, 1920s. Fair to say we've expanded a lot since then. And this will be the new St. Paul's. 2027, that's what they told us. So I imagine it'll be a little late, but we're getting a new hospital. It's design hopefully will also help our workflow. There's a building that's similar to Diamonds at VGH, where you have all the ambulatory clinic here and then a bridge. I'm very curious to hear what they're going to do here in the non-acute side. But anyways, back to where we were. So how do we take all the lessons and start a stewardship program at St. Paul's? And I think these are the important factors, these 4 things that I think if we don't do well, it will never fly. And specifically, I highlight money. Many of you will know, without a sustainable plan, it's impossible to sustain a program. Most of the programs are so stretched financially. In order to get more funding, the money needs to come from somewhere else. And that's a lesson that we learned when we built a thrombosis clinic here in St. Paul's and also our DVT pathway. We need to reduce costs somewhere. So this money can be used to put into innovative stuff. We need to align ourselves with the health authority and the ministry priority. And once we have their backing, it is much easier. We need to implement best practice guidelines. A lot of things in medicine is subjective. It's nice to have some sort of standard and guideline that's all well validated, well designed, so we're not reinventing the wheel. And lastly, and the most important thing is we want to improve that patient safety. So how do we solve the money part? This is how we think we can solve the money issue. Close to $20,000 a month spent on enoxaparin 40 milligram syringe on the medicine ward at St. Paul's. So I asked our pharmacy colleague to pull up some data, financial data. This is how much we spent. It's the 5 medicine wards plus the 2 geriatric wards. So 7 wards in total. That's how much we spent just on enoxaparin 40 milligram syringe a month. So a year, you're looking at over $200,000. Not a small number, but it also means that we have a great opportunity to help reduce the cost. And yes, we can align ourselves to ministry priorities, health authority priorities, and also health authority approved guidelines. I think this is not well promoted or communicated to the physician body, but in VCH at Providence, we do have a VTE prevention guideline that's quite well written and very specific. And I just want to highlight these 3 points. It's the physician's responsibility to evaluate everyone's VTE risk when they come to hospital. Not only is it important, we also have to document it. And I have to say that we are not very good at it. And this is often something that we kind of brush off. You know, patients coming in, they're sick, there are 10 million things that we need to deal with. We often forget it. Again, room for improvement. We've had amazing tools that are developed for us. Many of it is already embedded into Cerner, including this nice educational tool, created by Karen, one of the pharmacy leads at VGH, describing the improved score. This is actually the scoring tool that our health authority decided to use in assessing the VTE risk. Some literature will quote that about 70 to 80% of the patients are actually low risk. I personally think that is a little exaggerated, at least for our patient group. What's more important to remember is this tool was very well validated in multiple studies. If you look at all those studies put together, you have more than 60,000 patients, 60,000 medicine patients that were used to validate it. It is very important to know that when they're low risk, according to their improved risk score, it translates to about a 1% risk of VTE in hospital, fairly low, at a point that we should feel comfortable in stopping VTE prophylaxis. Some of our colleagues try to educate the resident body and really promote it, because we know it is our residents who will be admitting most of these patients. And Tristan and VGH and Aggie put together this changed my practice article a few years ago. So I think some of our residents are becoming more familiar with it. But again, the communication can be better. And lastly, I'm going to highlight this because we at St. Paul's just went through accreditation. I actually got an email from one of the hospital leads and asked me about this specific issue. I did not realize that documentation of VTE assessment was actually a check mark or an item in the hospital accreditation. We're not talking about academic accreditation, we're talking about hospital ministry accreditation. And I don't think we're very good at documenting VTE assessment. At most, you see in someone's console will be enoxaparin for VTE prophylaxis. There's no assessment documented. And then lastly, some of you may know that fairly recently, UBC partnering with VCH created a planetary healthcare lab. The lead is Dr. McNeil. I believe she's an oncology surgeon at BCC and VCH, to look at ways how we can lessen our carbon footprint. And again, it also means that the stewardship program will be aligned with priorities from the health authority and also from the university. With that in mind, we dig further and try to find some baseline data from our own hospitals. So we actually got a lot of help from our HemePath colleagues. We dig up the statistics for HIT assay. We got a year worth of data from 2020. So I think still fairly good in terms of it's not too old. At St. Paul's, 66 HIT assay came back or was ordered in 2020. We had 11 positives. As you can see, majority of them is from ICU and cardiac surgery. And again, I'm saying St. Paul / Lionsgate sends samples to us as well. On the VGH side, which also takes in the Richmond Hospital samples, 80% 87 hit rapid assay was ordered, 15 came back positive. And as we can imagine, majority of them in the ICU unit or the neuro ICU unit, cardiac surgery, and so forth. So we just don't have all the granular data in terms of are these also confirmed with SRA? Do these patients have clots? We have a very brief privacy access approval. So these are the kind of the level of data we can get. The more granular data we will need to wait until we have our ethics approval. But it gives us a ballpark in terms of what is the hit burden in our hospital. We also did a chart review to look at people coming into CTU, specifically St. Paul's, and see how we are doing in terms of documenting VTE risk. Right here, the first step is that someone in the medical team documented VTE risk. Fortunately, our rate is quite low. Only about 11% of patients had a documented risk, either by the resident or by the CTU attending. And the other important part is that about 43% of the time, there is no linkage between the VTE assessment and the proper prophylaxis that's been ordered on the module. It is not an easy thing if you want to do admission on Cerner. I think we all know now. This module actually is somewhat hidden. So it's not surprising that a lot of people miss it. But even Cerner workflows aside, and we look at the medication that was prescribed, 24% of the time, the prescription of prophylaxis actually did not match the VTE risk. So lots of room for improvement, and I think this is where we're going to have a lot of our impact. In other stewardship programs, they also look at whether the nursing staff was able to administer it, and also whether the VTE risk was reassessed in the hospital. For example, patient transfer from CTU to let's say hospitalist type of a ward for rehab. Obviously, we don't have that granular data right now. I would imagine this number is higher in St. Paul's because it's not unusual for our patients to refuse these type of medication. So if we focus on this, the 24% of quote unquote failure rate to use guideline recommendation in terms of VTE prophylaxis, how can we make it better? I have a few slides here from our pharmacist, Stephanie. We actually presented this to the CT group and also the resident body as well. We want to highlight to them that 24% of the time we can optimize a VTE prophylaxis. And a lot of these are actually from low-risk patients who were put on prophylaxis without a clear reason. A lot of these patients are coming in, they actually are not high risk for various reasons. It is sort of a knee-jerk reflex that we just put people on enoxaparin. We have posters like this up on the ward and also communicated with the residents that the reasons why we're doing this is threefold. It's good for the patient, reducing an adverse effect, good for the system in terms of the cost, and also it helps the planet. What is our workflow? Essentially, Stephanie, our pharmacist, will be reviewing patients 3 times a week, Monday, Wednesday, Friday. According to the documentation, she will assess the patient's risk by the improvement score. If there is any suggestion, she will contact the CTU team pharmacist or the CTU team directly. Very similar workflow to the antimicrobial stewardship team, and we've grown to get used to it. As most of us here with the CTU we interact with the antimicrobial stewardship quite regularly. And this is the way Cerner communicates the risk score to the physician. Again, it's a very hidden text box. Most people will just scroll through it without looking at it. We started almost 4 weeks ago now, and we have some prelim data. So I'm hoping to share with you. Again, we're early in our journey, and lots of learning already. So in the past month, we look at all the admission coming to CTU that went on to the 7th floor. So we're starting off very small, and we found that about 18% of the time, the VTE risk was documented on admission, 82% not documented. Again, this is already a little better than the data I showed you earlier when we did the chart review a few months ago, because we had an opportunity to go and talk to a resident. Hopefully, in the weeks to come, we'll make it even better. We were able to review 159 admissions to CTU, and out of all these admissions, about 48% of the patients are actually low risk, according to the improved score, leaving 52% high risk. As you can see, we do very well in putting high-risk patients on DVT prophylaxis. Out of all the high-risk patients, majority are on it, 87%, and the rest of it is essentially not on because of contraindications appropriately. So we really need to focus on this. So out of the 48% of low-risk patients in that group, still 34% of patients were prescribed DVT prophylaxis against guideline recommendation. So we need to really hone in on this part and understand why the team felt that there was a need. We also look at the ALCs. So the patient I talked about before, we assessed them very early on when they come to the hospital. Then we also went into the ALC patients on the CTU team and look at their risk, because the risk can change. Of all the ALC, 43% of them were low risk, 57 high risk. And again, we're very good at keeping high-risk patients on DVT prophylaxis. But more than half of the low-risk patients were put or kept on prophylaxis for no good reason. So we've had patients that we saw, they've been here for 3 months. They're essentially just waiting for long-term care. They're actually walking around the ward for the last 2 months, but still every day we're giving them a prophylaxis for no good reason. And I think that highlights the lack of reassessment. So this is actually a very high yield group for us to go in, because we're able to prescribe a lot of these patients. And again, ALC patients, often they get rounded on maybe once or twice a week. And it's not a very thorough medication review often, because some of these teams may not have pharmacists with them. So far in the last month, we made 52 recommendations. 56% of the time, the MRPs agree with us and made a change, and we're able to deprescribe 21 patients. And looking into some of the reasons why the MRPs do not agree with us, Stephanie's here, she'll know better, but a lot of it is actually patients just being discharged very quickly. For example, they're quick turnaround admissions. They're only here for a day or two. So there's a knee-jerk reaction to put these people on prophylaxis. By the time we get to them and suggest stopping, the team's like, oh, by the way, patient's going home. So a lot of these patients with, alcohol withdrawal, drug-related complications, they're really here for a short stay, or they're here for cellulitis and a few days of IV antibiotics, they're gone. So a majority of them is like that. But it also brought the other concern from the team is that improved score doesn't capture sepsis. A lot of the physicians felt that even if the patient has no other risk factor, the fact that they're in for pneumonia makes them high risk. So they will feel more comfortable keeping the patient on prophylaxis. Another group is the IBD patients. Again, the improved score does not capture IBD patients specifically. And I'm sure as we run the program, we'll learn more from the physicians and in what setting are they less or more comfortable in stopping prophylaxis. How are we going to sustain it? We are very fortunate to have funding with help of the foundation to support our clinical pharmacy specialists. And again, after a year, we still have to see whether we will have the funding renew. again, I think whether we can renew the funding depends on these three things. Can we achieve some sort of significant cost savings? Like I said, every month we're spending, at least in the medicine ward, $200,000 on enoxaparin. If we can cut that down by 20%, that's a substantial cost saving. At the end, we also look at HIT. Because we're still early in this stage, I don't think we'll make a lot of progress in reducing HIT. Probably maybe after a year, we can look into it. And once we have get more comfortable, our next step is actually to look at all the unfractionated heparin infusion protocols. I've been working at St. Paul's for 5 years on CTU. Without a fail, every year there is an MMM related to unfractionated heparin protocol. And most of us in thrombosis, hate it with a passion. There's often a good alternative to unfractionated heparin. So hopefully after a few months, when we get more comfortable with the program, we'll extend it to reviewing all the unfractionated heparin order and try to make some recommendation around that. The last aspect of it is the nursing workload. We will be surveying the nurses later. When we started this program, we approached some of the nursing leaders and let them know. One of the first things we heard was that there has been incidents where our nurses were assaulted by patients when they go in to give the subcutaneous enoxaparin injection. I can imagine that someone is, under the influence, they're withdrawing, they're delirious, they're hyperactive delirium. You go in and you give them injection. I can see how sometimes it can turn into agitation and patient acting out. So it is a big deal for nurses. We'll survey them. And also the fact of them going through this process. They have to, on Cerner, sign out the medication, go to the Omnicell, pick it up, go to the bedside. If the patient is able to, talk, they have to go through you're bleeding, all the contraindication, give the injection, come out, document on Cerner. That process probably takes about 10 minutes. And every single of the patients are probably on it. If they carry 5 patients, that is 15 minutes a day doing this work. If we can reduce that, that is substantial. Because nurses are so stressed, the more time they have, they can do other more higher impact or high yield care for the patient. So we'll see what type of results we have after a year. Hopefully we can renew our funding. And lastly, we're also fortunate to have some support for our physicians, partly from PLQI, and we can also build some fee for service from our work with the pharmacists. I think that's about it. So it is an unknown journey. We're early into it. I'm very glad that I'm sharing with you guys today. Happy to hear from the group if people have other experience about stewardship, and hopefully in a year I'll report back.